Hello there, I'm Johnny Coxon, GP down in Brighton and one-time urology trainee. This is just a little video to accompany the article I've written with fellow GP and urology enthusiast John Rees in Trends in Urology and Mental Health on avoiding medical errors in general practice. For me, this was an interesting return to an area that I was closely involved with a few years ago when I ran a patient safety training course at St George's Hospital. That in turn was born from discussions between Professor Roger Kirby and an airline pilot called Captain Peter Stevenson on how the medical world could learn from the aviation industry to reduce the chances of errors arising or escalating. As we say in the article, there tends to be more focus on errors that occur in the world of hospital medicine, and of course the stakes are often higher in that environment. However, it would be wrong to assume that the critical errors are not arising in general practice as well, sometimes with devastating consequences. Certainly there's plenty of mistakes happening all the time in primary care, covering the full range of degrees of severity. This comes as little surprise when we add together factors such as the great majority of consultations occurring in primary care, the increasing workload pressures that we're all under, and the huge variety of cases that we encounter. For understandable reasons, there's regular media focus on medical error, and there's been a fair bit of coverage on related matters here in Trends, including discussions on one particular case that culminated in a custodial sentence with a surgeon involved. While no one would ever accept outright negligence, it's of course vanishingly rare that anyone has any intention other than to do their best for the sake of their patient primarily, and also for their own reputation and pride. However, we all make mistakes. We've done it already and will continue to do so. Whilst we might strive towards it, it probably isn't realistic to never make another mistake, but we can arm ourselves with some awareness and techniques to lessen the risks of error either occurring at all or continuing unnoticed. Our article looks at how often we're making medical errors, what the most common ones are, and indeed which are more likely to end up in potential negligence claims. It seems that diagnosis and prescribing are two areas where mistakes are especially common, both in terms of frequency in general medical care and also in medical negligence cases. We list a few of the eventual diagnoses, often initially missed diagnoses, that most commonly arise in our practice claims. Many won't come as any surprise, but serve as good reminders for us all to always up our level of vigilance for them. They include infamous favourites such as subarachnoid hemorrhage, pulmonary embolus, cauda equina syndrome, appendicitis, and so on. When it comes to diagnostic errors, the cases are often multifactorial in what's come to cause them and include features like faulty clinical reasoning, misinterpretation of results, or exacerbating factors inherent in the systems within which we work. A good deal of attention is often paid here to well-recognised mental shortcuts that we can all be prone to and which can help encourage the unnoticed emergence of faulty decision making. These shortcuts are also known as failed heuristics, and we discuss a few of the more common examples, such as availability heuristics, which describes a tendency we all probably recognise to quickly attribute a clinical presentation to an obvious, readily available or recent diagnosis. Anchoring heuristics also represent a common phenomenon, equally well recognised from root cause analyses of aviation disasters, whereby we may find it hard to break away from initial impressions made by ourselves or others, and that reminds us, simply put, to always challenge our first thoughts, not allowing them to get set in stone. Talking again there of the airline industry, we know full well, having seen enough of them on the telly and in films, that pilots always go through a set checklist of things to do before, during and after a flight. Could there be lessons there for us to learn as well? Humans are of course a rather more erratic beasts than aeroplanes, but there might still be room for some systematic checklist to aid the art of medicine, which will always remain essential. We also briefly consider prescribing areas, and it's a particular interest that a recent European study attributed nearly half of these areas to just 7 drugs or classes of drugs. Of course, of these, not surprisingly, methotrexate really stood out. The others were digoxin, warfarin, aspirin, and the drug classes beta blockers, NSAID and opioids. So a good reminder there for us all to be extra wary when signing the scripts for that lot. We discuss a few other tips that can help us reduce or eliminate our error count. A theme that comes up more than once is an essential need to be open and honest with ourselves and our patients, to be aware of our limitations and to own up to them, and to encourage our patients to tell all their story, giving them time and opportunity for all relevant features to be discussed. Finally, when the inevitable probably does occur and we do make mistakes, the impact can be lessened by, again, respecting our patients' views and rights as openly and as soon as possible. As last year's review of Candour from the Royal College of Surgeons reminded us, when things do go wrong, patients and their families expect three things: to be told honestly what happened, what can be done to deal with any harm caused, and what will be done to stop it recurring. Doing that will also enable us to offload some of the burden that errors can bring, help us to gain advice from colleagues, and encourage us to scrutinise those systems we work in. So as we know, to err is human. It's a case then of how often and what we do about it.